Hello, everyone. My name is Dr. Cassie DeSena Jacobs. I am an assistant professor here at the VCU School of Social Work and the director of mental health initiatives. I want to welcome you to Serious Mental Illness in Focus, specialized topics for practitioners, and our second session, Pregnancy and Motherhood with SMI. The speaker in this talk is Ariel Hill-Thomas. Ariel is an RN and a PhD student with the VCU School of Nursing. The seminar is going to discuss the many challenges that pregnant women with SMI face during pregnancy and connecting with appropriate mental health care and support. Ariel does mention in the beginning of this video that there are many different individuals that experience pregnancy, but because the research focuses on women or people that she, her identities, that is the identity in which Ariel speaks about. But Ariel does say, and I just want to reiterate again, that many different individuals can and do experience pregnancy. So during this seminar, participants had the opportunity to discuss challenges pregnant women with SMI face when connecting with appropriate mental health care and support, review factors contributing to mental health disparities in this population, and discuss what trauma-informed care looks like with the population. I also just want to talk quickly about our speaker. Ariel Hill-Thomas, like I mentioned, is a PhD candidate in the VCU School of Nursing. Her research is focused on improving care experiences and maternal health outcomes for pregnant women with serious mental illness. Her ultimate goal is to help women with serious mental illness feel empowered in pregnancy and motherhood. Ariel has been a registered nurse for 7 years with experience in neonatal intensive care, pediatric and adolescent health, and nursing research. Ariel currently works as a nurse care coordinator for teens and young adults with eating disorders. Ariel is a Chicago native, and in her free time, she loves to spend time with her dog, Kofi. I hope you enjoy this discussion. I think Ariel is an incredible speaker, and this has been one of my favorites so far. Have a great day.
There may be a patient that needs a more urgent referral, but they were put in for a routine referral. So that's a common thing that happens. And then also, once you get referrals placed, the wait time for a new patient appointment or appointment with these specialized providers is very a long wait time for the specialized providers. And then the last point is the lack of secondary care community perinatal mental health services. So what that looks like is, okay, we're receiving care through at the hospital in our clinics, but also having a resource for these patients in their communities, some like a peer support specialist or someone they can call on when they are having, increased symptomology or things of that sort. And so the leaders in this type of research right now is the United Kingdom, but I would love to see the United States do more of this research, and that's why I'm here and hope to add to the research that we do in this area. I also think it's important, just as a nurse, I'm nursing by background, but to point out the consequences of the health disparities for each serious mental illness. And so, pregnant women with bipolar disorder, 37% of pregnant women with bipolar disorder are at risk for relapse. And relapse for pregnant women with bipolar disorder is very important because this population is at the highest risk for developing postpartum psychosis. Postpartum psychosis is a very much so medical emergency that often leads to suicide as well as infanticide. So I want to bring to light and discuss really quick. We all see the stories in the news about the mom that unalived her child, unalived herself. And we're like, oh my God, you always hear the chitter chatter just saying, like, oh my gosh, she's not fit to be a mother, or she's not. Most of the time, when I'm reading these stories, it sounds as though the woman was in an episode of postpartum psychosis and she didn't get the help that she needed. And so it's very sad that, that's kind of how we view those type of scenarios. And I'm not saying that every scenario is that, but when you dive deep into some of these stories, it does sound like postpartum psychosis, which is very much so a medical emergency, and the mom needs help, and the baby needs to be with someone for safety at that time. And then also too, pregnant women with bipolar disorder, their babies are found to be small for gestational age. Pregnant women with schizophrenia and the babies born to them are often found to have intrauterine growth restrictions. So that just means that baby is not getting enough blood flow, and that impacts their growth, and they're not growing in utero as much. And then compromised APGAR scores. So APGAR scores are what we use for a newborn assessment following delivery. So as soon as the baby's out, we're doing APGAR scores just to make sure that that baby doesn't need increased intervention, some oxygen, things of that sort. And then they're also at risk for congenital defects. It is found that pregnant women with schizophrenia are known to have more obstetrical difficulties than any other mental illness in this population. And so these are some of the complications that there are found to be most at risk for is preeclampsia, placental abruption, gestational diabetes, induction, and being induced in C-sections. And then pregnant women with major depressive disorder, we see poor mother-baby attachment, more thoughts of self-harm, decreased number of newborn checkup appointments. Some moms just miss it because they just don't have it to go. We see low birth weight, and we also see substance abuse and preterm delivery, and also, of course, suicide. So, a lot of what impacts this population, what I've seen in my research, is stigma. Stigma just overall plays a huge role in serious mental illness overall. There's a huge stigma against serious mental illness and just any type of mental disorder, mental illness in this country, in this society. People just do not view mental illness in the way that we should. And so I found several types of stigmas that pregnant women with any mental illness face, and I actually have some excerpts from some of the articles that I have to give you guys examples. So, experienced stigma is discriminatory acts, adverse perspectives of providers. There's internalized stigma, poor feelings towards self, associated stigma, so stigma towards family and loved ones, and then structural stigma, so barriers to resources that support the maternal infant dyad. So this is a good example of experienced stigma, and I'll just read them really quickly. It's implicit that they view those of us that have got bipolar as not having adequate parent skills. So it's an automatic assumption, and I see this in the research a lot, that mothers with serious mental illness, with any type of mental illness, they're not good enough to be fit to be mothers and be parents. And I just think that's completely wrong. That's not something that we need to determine. If anything, we should be supporting them to be the best parents that they can be with their mental illness. Then you have internalized stigma. So this one says, I worry whether some of my friends will say, should you really be having children? You've got mental health problems. What happens if you kind of drown your baby? These are real quotes from women with serious mental illness, and these are the things that they are thinking. This is that internalized stigma, the thoughts that go in their head as they're trying to process becoming a parent and maybe becoming a mother. Um, um, Both experience internalized stigma is in this last quote. So the doctors or my family never brought up the topic of conceiving a child, but I wanted to. I had many doubts related to that, but every time I was afraid to ask, as I felt it might lead to some uncomfortable moments, questions, or discussion about my medication. I didn't want the doses to increase. I already felt sleepy. So these are just multiple, it's a lot of layers in this quote, right? It's that, oh, I wanted to bring this up, but I was fearful. I know it will lead to this. What will the provider think? So it's so many things and so many layers in this one quote. So that's why I said it's a little bit of experience stigma and internalized stigma. Then you have associated stigma. So this quote is from a partner of a person who is a mother with serious mental illness. I've never really talked to, and he was referring to the early intervention service coordinator. Like, she comes here and talks to my wife, doesn't really say much to me, doesn't ask me, how do you think she is, or things like that. I mean, nothing. It would have been nice for her to say, well, I'll involve you in some of the meetings, but you don't get nothing. So this dad just felt like he was completely cut out of the experience, and that's not right. The support that these women do have, we should be including them in any resources or any care that we provide. And then last but not least, this is the structural stigma. It took a long time to visit him, the psychiatrist. A lot of things would be discussed about how I'm feeling, whether I'm taking my tablets correctly, how my family members see my improvement. But at every visit, there was little time for my concerns, and it happened to be postponed. So I put this under structural stigma because what happens here with these women and their care experiences is that there's little time to address their concerns. So when their concerns are not addressed, therefore they're not connected to the resources that they need. So that, to me, screams structural stigma. If you're not hearing my concerns, I can't get the resources that I need. And so that's why I put this quote under structural stigma. So I really do believe that we as a society would think differently about mental illness and serious mental illness if we understood the intersection between trauma and mental illness. So I think everybody has their own definition of trauma, but a kind of conclusive definition that I wanted to bring to you guys, it's an emotional or physiological response caused by a single event or series of events that cause significant distress, or events that are out of your control that impact your physical, mental, um, uh, psychological, and physiological well-being. And so there are a lot of different instances of trauma. Of course, we have ACEs, we have racism, discrimination. There are a lot of things, as you guys know, you guys probably studied that. The list can go on forever, what goes under trauma. And so I just want to talk about really quickly about the intersection of trauma and mental illness. So people who have experienced trauma are at an increased risk for depression, anxiety, and PTSD. Trauma can also increase the risk of developing schizophrenia, bipolar disorder, and borderline personality disorder. Adverse childhood experiences increase the risk of developing mental illnesses in adulthood. And then it is found that emotional abuse also has a positive correlation with mental illness severity. And then last but not least, most women with schizophrenia and bipolar disorder have a strong history of ACEs. And so what they recommend in this particular article is psychological trauma focused interventions are highly recommended in treatment. And so this is why trauma informed care is important. And so what exactly is trauma-informed care? I'm sure that you guys all know what trauma-informed care is, but this is a great definition that I wanted to put on this slide. I won't read it because I know everyone has their own definitions, but I do want to pay attention to the box. And I pulled this from the Center of Healthcare Strategies. And I do recommend that everybody visit the Center of Healthcare Strategies website. It has a lot of great information on trauma-informed care and implementing trauma-informed care. But what trauma-informed care looks like is patient empowerment, empowering our patients within their healthcare journey, giving them a choice, which matters, right? Specifically for pregnant women with serious mental illness, because a lot of times their autonomy is taken away from them, not just by providers, but also by their partners, by families. Like, nope, we're going to take over this because you're not well enough to journey throughout your pregnancy or make decisions throughout your pregnancy while you have a serious mental illness. And then also collaborating with our patients. And collaborating with healthcare staff, making sure that our patients are getting the care that they need. Safety, definitely cultivating a safe environment with the patient is very much so important to trauma informed care. And then that leads to trustworthiness. Um, just having clear expectations with the patient, and then being open and honest and transparent about what their pregnancy journey may look like, or what their medications, how their medications may change. Women with that are pregnant with serious mental illness, and I'll talk about this a little bit later, they really do want that information. They want to know how to have a healthy pregnancy journey. And so what does trauma informed care and mental health services looks like? There's like very little research about this, especially specifically for pregnant women with serious mental illness. But what trauma informed care and mental health services just looks like shifting the narrative from what's wrong with you to what happened to you. And that's just kind of what we talked about before with understanding the intersection between trauma and mental illness. And I think having that perspective will also help people shift their care practices to trauma informed care when they give mental health services. The known benefits of a trauma informed care and mental health services is it establishes trust and safety. It improves the patient experience, reduces stress for the patient and provider, prevents further traumatization, and then also increases patient autonomy and empowerment, which is what we want for these moms. The American Psychiatric Association actually recommended that the implementation of interventions that focus on stress reduction and building community to prevent mental health relapse in pregnancy. So those are the two things that they found important to reduce the instance of relapse. So I completed a scope and review that talked about the care experiences of pregnant women with serious mental illness. My big question for this scope and review is I want to hear more about the care experiences with pregnant women with SMI. What is actually going on? How are the patients feeling? How are the providers feeling? I found a lot of information. There was 16 articles used for this scope and review. And I found a lot of information about the areas that are vital to the pregnant patient's experience within treatment for SMI. It's found that these women really value specialized providers for treatment and care. They like meeting with providers that know what they're talking about, know how to guide them in the correct way. They also value preparedness in the pregnancy journey. I know there's this stigma for this population, but they actually want to be prepared. They are aware of their mental illness, and they still want to have families, and they still want to have healthy pregnancies. So they want the information that they can be, and they want to be prepared for what their pregnancy journey looks like. And then also, they want to have access to quality guidance and information. I saw a couple of quotes in some of the articles. It's just like, I met with this doctor. She didn't know what she was talking about. I knew she didn't know what she was talking about. They get that a lot. They want to connect with people that can give them quality information and real guidance. Sometimes they want things to take home to refer back to. And then also going back to that attention to addressing issues and concerns. Women in this population really like for providers to take their time and address all their issues and concerns. They have a lot of questions, and like I said, they value being prepared in their pregnancy journey. So there's going to be a lot of issues and concerns that come up. And then guidance with medication, which is a huge piece of the puzzle here. And that is very much so a big component of relapse. It's just women just stop taking their medication because providers, they're say what happens is that they'll be meeting with their psychiatrist, they get pregnant, their psychiatrist may not know how to manage serious mental illness and pregnancy. So they're like, I don't know what to do with your medication here. I don't know what's safe and things of that sort. So they refer them out. What happens during that time that they're referred out? what guidance are they getting for their medication? So they really value, like, I need the information to know how to manage my medications. And then also care integration. During this time, it's very important for the obstetrician to communicate with the psychiatrist and things of that sort. They really do need a team to work cohesively together, and that's very important. And then I found um, um, very few literature about what the provider's experience is, and that's going to be my dissertation. So and what I did find is that communication providers find that communication within the care team is very important for their experience. And then specialized knowledge and expertise. They want to know, how to care for these patients, and they want to get the information on how to care for these patients. And so that brings us to our discussion. And what I wanted for us to discuss, because I do come from nursing by background, and everybody else mostly on this call is from the School of Social Work. I think that social work and nursing is very much so important to this population in implementing trauma-informed care. So I just wanted to brainstorm and discuss with the class. Of course, any questions about the presentation, I'm happy to answer, but I would love to hear your ideas about what does interdisciplinary trauma-informed care looks like for pregnant women with serious mental illness after we reviewed all of that information. And then I'll stop sharing my slides, guys. There we go. Okay.
So Ariel, do you want them to answer the question first, or do you want them to ask you questions first if there are any? How would you like it
Oh,
to be facilitated?
they can ask their questions first, because I think that may help facilitate the discussion better, and then we can move into that discussion piece.
Okay, great. So Ariel's opened it up. So does anyone have any questions for her for the information that's been presented?
Oh, hi, Ariel. I don't know if you can hear me. Should I talk?
Yes, I can hear you.
My name is Stephanie. Your presentation was extraordinary, so I just want to thank you for your time. And one question that I had when you were discussing for babies that were born from moms that have a serious mental illness, and some of the, what we were seeing with babies, premature delivery, the low APGAR scores, were those women, or maybe we don't know, but were they on medications during their pregnancy?
Don't know. We
We don't
don't
know.
know. Yeah, and I wish we definitely had more literature about that, whether they were on medications or not. Most of the time, if they're being hospitalized, and that's where we kind of see some of these these effects happen to the baby, most of the time they're in a state of psychosis. And so my assumption would be that they are not on their medication at the time, but we don't know.
Because it's challenging if the doctors are not wanting to give them the medication, but we don't even know. Yeah.
Yeah, it's very difficult.
Yeah.
Ariel, I have a question for you. In your research, I don't know if you came across this, has there been any research or discussion about pregnant women with SMI and psychotherapy? Is there any, you know what I mean? Is there any correlation to better pregnancies or better outcomes?
Yes, I think that the literature that I reviewed is that anytime they are connected to psychotherapy, because that's a part of that community support, right? That we were talking about in the stress reduction. If you have someone that you're talking to about your problems, of course, you're going to have reduced stress, and you're going to feel supported. So yes, I've seen significant impact for this population if they're connected to psychotherapy during this time.
Okay, thank you.
Yes, Sydney.
Hi, thanks so much. Great presentation. I have two questions that I'll combine. Do you have any more insight on why there's such a lack of clinicians willing to work with this population? Is it just like they're worried the stakes are too high? And then second, how much research has been done on like, can pregnant women take these medications? Like, does it affect the baby, that kind of thing?
So that kind of goes hand in hand, right? There is a large hesitancy, and the American Psychiatric Association talked about it. They said a lot of this undertreatment is just due to the providers being hesitant. This is a very complex thing, right? I know I probably just talked about it like it was a breeze, but at the medicine level, it's very, and at the psychiatry level, it's a very complex thing. And I think people are afraid of it, so they don't want to touch it. I went to a conference uh, this past year, and I spoke with some nurse practitioners who care for women with serious mental illness. And she just explained to me, she said, I was hesitant at first. And then she was like, I was given some information. I saw after that information, then boom, it clicked. I was able to guide my patients through their medication journey. I'm like, no, we're going to take these medications safely and things of that sort. I just don't think enough providers are having that aha moment where they feel comfortable enough to manage this population. And so that goes hand in hand about the research. The specialized providers who actually are very much so passionate about this population, they are doing research on how to safely provide medications to women in this population. There is research out there for sure.
Thank you so much.
No problem.
I had a
Mhm.
question for you. Oh, sorry, Christine, you go first. I'll wait.
Mine's really quick, sorry. You spoke about access, which makes sense because in the serious mental illness space, there doesn't seem to be enough providers across the board anyway. But did you run across anything, especially more recent times, about insurance coverage or the fact that not only are there not necessarily enough providers, I didn't know if anybody was studying that even if you're in an area with providers, do you have to have the means to pay out of pocket? Because it seems like that's becoming more of an issue. But I
Oh
don't know if
yes, that's a great question. And that's where a lot of my women, a lot of the women in this population, they go to their communities for support. They'll seek out your non-for-profit community organizations. And that's why those secondary care mental health services are important for those, because also to not just not being able insurance problems and not being able to seek out those providers in a larger healthcare system. So there's medical mistrust, right? Like I don't want to actually go to the healthcare system and things of that sort. But I have not dove into the actual like insurance part, but I do know that there are many women who seek out those kind of non-for-profit organizations that don't charge anything at all. They just want to get connected to support services like doulas and peer support and things of that sort.
that makes a lot of sense. Thank you.
You kind of covered part of my question, but the number that I took away that was staggering was that like 70% of people mask because of their fear. So my question is, have you attended any or do you know of any really great psychoeducation that is provided to providers around that, around what that masking looks like? And if you do, can you tell us a little bit about it? And if you don't, what do you think that should look like?
So I actually don't. I haven't found any literature. Actually, I do. I think she's on the on the call. I have a friend that's on the call. And her name is Sarah Moyer, Dr. Sarah Moyer. And she has revamped the EDPS, yes, that is used for measuring depression in pregnancy. And what she did with that tool is change the language. She's actually really amazing. She got permission from the person who created the tool and changed the language to one that women can actually answer the questions, because the questions before were a little confusing, like, what does this mean? So she did a lot of work in changing the language of that screening. So I think for this population, it's just meeting people where they are, not using a bunch of medical jargon, and also I know we can't do this in our current healthcare system, but taking the time to talk with them, because the more that you talk with them, the more they, sometimes that mask comes off, once you talk about their lives and the things that they're experiencing. So I really do believe that it's not so much using tools, but it's also using the tools in assistance to the screening that has to happen when you're interviewing the patient.
As a social worker, I love that answer, and Dr. Moyer sounds incredible as well, but we think you're incredible, so makes sense. Thank you.
I have a question. My name is Cameron Law. I was wondering, within like the literature that you've reviewed, did any of these patients like have interactions with like care coordination teams or like case management? Did you see like any things in regards to like fragmentation of like care?
Absolutely. Yeah, so I actually found, I don't know if everyone knew this, and I should have included a little bit of information, but a subset of this population that is actually known to have very few resources are veterans, women who are in active service on base, pregnant, dealing with some type of mental illness. They are found to have difficulties in receiving the care that they need. So I did find a review article for specifically for that subset of this population, where the providers made more of an effort to kind of connect with the primary care, connected with the obstetrician and the psychologist connected, and they found more success when they were like, hey, let's debrief about this patient. And then they also added care coordination into the mix, and it just made the experience for the woman better, and it made experience for the providers better. So yes, care coordination is a huge part of this. And that's kind of why I want to continue my research amongst the providers, because I do want to see what ways can care coordination help a little bit more. Do we need to create a care coordination model? What do we need to do to help these providers feel more empowered when caring for this patient and less hesitant? So yeah.
Thank you.
I had a question that's very similar to Cameron's in the sense of like working in care coordination teams. What I'm learning right now, my placement is even when social workers feel like they can't do much, there's always something we can do, and it always comes down to advocating. And I wanted to ask, especially when you work in interdisciplinary teams, what is the best way for social workers to advocate if you're working with a mom who's going through this and doesn't feel like they're getting the care that they need? How do you work with providers? Because I know it can be very sensitive of like stepping on toes, and obviously, at least I'm not in a place where I know about medication management, but just in the sense of like advocating for moms who are going through issues where they feel like they're not getting their mental health needs met.
Absolutely. So I think it just takes time to what you need to bring to providers, especially providers that are not hearing you out, is just what I've learned in care coordination, because I'm actually a care coordinator now, is that usually social work or nursing, they have more frequent contact with these families more than the providers do. And I think after a while, you start to get to know these patients, and then you're like, something's off. So you start to just collect this evidence through your assessments, your observations, and you keep bringing that to the medical provider. Like, hey, I know, you said it's, back to that medical gaslighting, right? Like, oh, she's just normal, or she's just having an anxious moment. Like, just constantly advocating for them. And that sometimes includes repetitive actions, but it comes through just constant observation and assessment, and even doing your due diligence. Sometimes with my patients, I do my due diligence to connect them to resources, even if the provider does not hear me out.
Thank you.
No problem. I do recommend for anyone who does like work with this population is just getting acclimated with the resources that are available to them to readily connect the patients to those things. So I follow, I think it's an organization, Maternal Mental Health Association. And right now they have like a list of perinatal psychiatry access programs. And this is kind of like supports in states and places that you can access and consult for this population. And then I think Sarah put her EPDS screening in the chat. Thank you so much, Sarah. Did that answer your question, Casey? Sorry.
Yes, it was perfect. I feel like I've worked in settings where you don't really feel comfortable because again, I didn't have the knowledge to be speaking on it, but I know my patient or the person I was supporting was not happy with the care they were getting, and so I felt put in weird positions. So I'm really grateful to hear that. And I feel like it just comes back to like how you approach things.
Yeah, it comes to how you approach things and taking that information and not taking it lightly, right? We're starting to see this in the medical setting where their voices are not being heard. And it's not totally the provider's fault at all. Sometimes I spoke with a psychiatrist who is a specialized provider. She mainly works with Black women with bipolar disorder. And what she told me after a conversation with her, she said, I get to my appointments, I have a 20-minute slot, but I realistically need an hour to address all of these issues and concerns for this mom. And that's also goes to a scenario that Cassie brought when I first took her class about how she had a mom that was in psychosis come to her office, and she kind of had to like cancel her entire, I'll let Cassie tell the story, but she had to cancel her entire day, to get this mom what she needs. And so I won't place blame on the providers. It is the healthcare system that we're in. And that's why I want to do more research in mental health services, because maybe these moms need larger appointment times. How can we implement that in our current healthcare system to address all of their concerns? And so I think most of the time nursing, social work are the glue between the patient and the doctor or the psychiatrist.
Yes. Thank you so much.
Has anybody on this call had experience with working with pregnant women with SMI? I'm just curious. Anybody want to share their experiences? Tara?
Yeah, either one, you're fine. Mine has been more in, it was years ago, but it was more in an emergency room setting, evaluating for suicidality, evaluating for those kinds of things. I didn't do it for very long, but it was interesting because as soon as a woman came in, people realized that she was pregnant in whatever stage of pregnancy she was in. Immediately the judgment started. Why was she having a kid? Why is this happening? Nobody should let her. I think some of the worst comments I got were like, these people should be sterilized, that kind of thing. So not only do you have someone who's in a mental health, a legitimate mental health crisis, but you've got someone in a crisis who have people coming at them in a really negative way. So I remember evaluating a number of women and sort of saying, what they really need is psychotherapy and some healthcare. Like they don't really need a hospitalization. And quite frankly, if I put them in the hospital, I put them at risk of losing their child because the hospital called CPS. Child wasn't even born. So my experience has not been positive.
And I thank you so much for sharing that, Tara. And me and what I think, if we reached hospitalization, we're too late. We're too late. We missed several times to intervene. And someone, missed something along the way. That's just the way that I view it. But you hit it right on the nail, Tara. They are met. And I just shared a couple of quotes from the qualitative research that I saw, but they are very much so hit with stigma to the point where they don't even want to discuss having children. They don't feel comfortable expressing that they want to be parents. And that's very sad, because mental illness does not disqualify you from being a parent. It doesn't. We just have to do better with providing them with the support during a crucial time. So yes, I totally agree with you 100%. My experience with this, and kind of how I got inspired. By background, I'm a NICU nurse. So what I've seen in the NICU is kind of this, and mostly with my mom's with substance use disorder, but we also know that that goes hand in hand with SMI. But I literally saw a set of twins. This mom, she was doing all that she could while her twins were in the NICU. They put on a good show that the twins were going to go home with her once they were done with their treatment. And when they got close to discharge, they told her they are not going home with you. And that broke my heart because she was trying her best to be the best she could for them once they left the hospital. And I know that happens with my moms with serious mental illness as well. And so I also transitioned to being a pediatric nurse in an ambulatory setting where I saw children of all ages, newborn up to 26 years old. But what I frequently saw is that sometimes mom came into their newborn appointments in a psychotic state. And the first thing that we did was call security and call DCFS. That's what it's called in Illinois. And it was sad. I mean, we're calling security not to make sure that mom's safe or baby's safe. They were calling security because they were afraid of how the mom was going to react. Well, I'm already in a psychotic state. You're taking away my baby. How does that make me feel? Is that the answer? And a lot of those times that we had those scenarios, we stayed late in clinic. Like there was one time I stayed late in clinic from 8 to 9 o'clock waiting for DCFS to come. And when they came, were they like super welcoming and super excited? No, and so no blame to there, no blame, because case management in CPS is very hard and it's very demanding. So no blame there. But I've just seen an immediately, like you said, Tara, we're just going to take the baby away. And that just causes even more distress and trauma. It really does.
Yeah. Yeah, I agree. And it's a sad situation that we're seeing. I did this when I was doing this, it was, 10 or 15 years ago. So we're still seeing it now. Like it hasn't changed in that amount of time.
I agree.
Yeah.
Thank you for sharing your experience.
Sure.
Does anyone else have any questions? Any more questions for Ariel? Because Ariel does have a question for us. I'm going to also put it in the chat because I have a copy of it too. And I want to give us all an opportunity to engage in this question for Ariel. So here it is in the chat.
So I'll start with something that I've been thinking about as you've been talking and I've been listening to the slides. Interdisciplinary care, right? We look at lots of different disciplines coming together for the benefit of this one person. So our problem when we talk about trauma-informed care is that not all disciplines are even educated in what trauma-informed care looks like. So you may have social work, which is in that, and nursing, I think, probably has some too. But not all disciplines do. So when you're talking about trauma-informed, I think we have to actually, as an interdisciplinary team, determine what that means for the team. I know I know there's stuff out there and there's research out there about what it means, but I think we have to actually, as a team, come up with what does that mean for us? How are we going to approach this client? How are we going to approach the care so that everyone is on the same page? Because the teams that I've been in, when they work well, everyone has buy-in to what the mission is, so to speak, and where everyone's kind of coming from is how I've seen teams work the best.
I love that. I love that. And just acknowledging that trauma-informed care doesn't look the same for each patient. It doesn't. And so, yes, for different cases, you will have to come together as a team and say, what does trauma-informed care look like for this specific patient who's been through these things and is at this point? So yes, I totally agree.
Yeah.
I don't have a question so much as another complication, so that's probably not very helpful, but I always think about the intersectionality and how if you have, a wealthy white woman who is married and, all the things, she's likely to get better help than someone who, like you said, some people are also addicted to drugs or have other issues. And just the fact that treatment already in the medical systems is so uneven. Have you come across much research on that? Because I feel like a personal experience with a relative who was treated really, really poorly in the medical system and ultimately died. There was a wrongful death lawsuit, all of that. And she was a Black woman. It was my brother's wife who should have been treated much differently. And it kind of always strikes me as I learn about hospital care at different levels or what leads to the hospital, like all the doctor's appointments and all that. And I was just kind of wondering if you come across that a lot.
Absolutely. I have come across a lot of research on medical mistrust and why care is often not sought out because of what you just said. And just going to the doctor, not their concerns not being heard. And that's also where a lot of like my non-for-profit community-based organizations come through. Like, for example, there's a awesome maternal mental health organization called Shades of Blue Project out of Houston, Texas. I attended their conference last year, and they do amazing work for Black women and women of color in regards to maternal mental health. And so, yes, that is very frequent. Another thing that I've seen in the research is that most of the time these women are misdiagnosed or they're not diagnosed at all. And so when you have someone that is not diagnosed at all, they're not getting the treatment that they need. And then also too, if they're misdiagnosed, they're getting the wrong treatment. So that happens a lot. So there is a lot of research about medical mistrust, what that looks like. And there's research out there how to combat that. And I think providers have to do their due diligence to seek that. And that kind of goes back to what Tara says in the importance of interdisciplinary care is because sometimes other disciplines are exposed to those type of statistics and that information, and that's what you bring to the table. If you may present a case and a provider is approaching it this way and you're like, actually we should approach it this way because the statistics say this and there's a common medical mistrust among this population of women. That's why I think interdisciplinary care is so important because everybody brings something important to the table. And I think that specifically for social work, I know for nursing, we don't have like specific focuses on serious mental illness. A lot of what we do have kind of like a psych rotation, right? But like if we want to dive deep into serious mental illness, you either do that within research or you do that within a psych MP program or a certificate and things of that sort. But what I love about social work is you guys are exposed to it, automatically because you guys are most likely providing psychotherapy or, journeying with patients. And so that's why I just think that every discipline has something they need to bring, and it's very important.
I think circling back like to the question, I think it does, like what Tara was saying, it does have a lot to do with the education and just the level of information like each provider has on what SMI looks like or like trauma-informed care. I don't know what like rounding looks like on different units. Right now, like my field placement is at VCU Health on the oncology, hematology floor. So like our rounds is more like, okay, when are we like discharging the patient? Like what's the medical stability? We're not talking about the social determinants of health, what this person's like mental health needs are, like if they have like a substance use disorder. Like when I'm looking through like someone's charts, that's what I'm looking for because that's what I'm interested in. But like you have to really look for it because it's hard to find. And I understand like the stigma of like reading someone's chart and like seeing those mental health barriers and stuff like that. But if I'm walking into someone's room, like I want to know those kind of things so I can get those resources for them. But I think in regards to like working with different providers on a team, like those things should be able to be brought up, not just the medical side of things. So I don't know, like on my floor right now, I'm trying to figure out a way to increase collaboration with the chaplain team, because I see that as like an opportunity to talk about these psychological, social, and spiritual aspects of the patient. So I feel like there's gaps in collaboration on certain units.
Absolutely. I actually saw this a lot in the NICU world. Baby's ready to go home. Um, we check off all the lists for for discharge, but we don't know what we're discharging the baby to. We don't know what type of environment we're discharging to. Does mom feel supported mentally, emotionally, and things as she's taking care of as she's bringing a preemie home and things of that sort? And so I do see that a lot in the hospital setting. And unfortunately, we all experience this. I experienced this as a nurse of just kind of being shut down. And I really do believe like a lot of this is finding your voice, is just saying like, hey, I really think we should take a moment and pause here and actually like look at this, because this can impact this, and just constantly advocating for the patient in that area, because unfortunately, sometimes they're unheard and no one else will bring it up. So that's like the best thing that I can suggest. And over time, you may get some people to back you, and then, you can implement it all together. But I know that's easier said than done. Finding your voice in amongst of different personalities and different disciplines, that there's very much so a hierarchy there. And so we have to try to find our way through that.
I just wanted to jump in on what you said, Ariel, because I think for me, working in a hospital setting, when I have experienced interdisciplinary care, um, it has been the struggle with other disciplines and ego. And what I mean by that is not everyone, like Tara had mentioned, having experience in trauma-informed care. And when you are the person who has trauma-informed care, kind of like what you're saying, Cameron, and you're maybe knowing what your client or your patient needs, and you're the one who's sitting at the table and you do, and then there are other disciplines who are at the table and they're advocating for that medical model piece, and you know that your client needs other things. I've personally struggled in my own experience with when is the time to bring it up, when to push, when not to, even with like years of experience. And I do feel like sometimes I can like see the egos at the table, even with years of experience in. And I think that's a really hard balance. But what Ariel just said, I think is really impactful. Um, what does the patient need? How is this going to be advocated for when they're no longer in the hospital, or when they're no longer in the community service agency, or when they're not sitting with me? And is my voice a voice that I can use in this moment? And maybe there'll be some things that I have to like navigate later, but is this moment a moment that will really bring impact to this client's life now? But that's something that I still think is hard even after all the years in the field.
I would,
Absolutely. Voluntarily stirring up trouble is hard. So, but sometimes it's very worth it. But I'm sorry, somebody else was talking.
Oh, I was just gonna chime in. I mean, I think I saw this firsthand in my previous role. I think in medical spaces, there's this real clinical lens, and peer support is not seen as credible, or even though it's evidence-based, right? But especially if you're working in a psychiatric setting, it's the diagnosis above all else. And so I've absolutely experienced that, to your point, Cassie, like there's folks who really just see the person as their diagnosis and nothing else. And so I definitely think we just need more peer support infrastructure and spaces, but that's just so hard because I think a lot of those models don't always bring in revenue for a hospital system. And unfortunately, that's sort of, not the world we live in. So yeah, I could say a lot more about that, but
I can
just,
too, Amanda. I really can too, but
yeah.
we'll talk all night. So
Yeah, I just know that, yeah, I was in a former role, and it was like at VCU Health, it was, not to knock VCU Health, but it's I think like in any large hospital system, there's all of these layers and competing factors, but having to argue for your legitimacy and talk to convince leaders that the service you provide matters, is very discouraging.
absolutely. And to back you up, Amanda, specifically for this population, as I mentioned before, the research that's being done in the UK, they are doing a lot of research around peer support and community kind of services and lay providers that are very important, right? And the research shows that the kind of lay providers in combination with the professional providers is known to be very impactful for the patient. But like you said, one is more lucrative than the other. And unfortunately, the way that our American healthcare system is set up prevents this kind of like light to shine on these services and how impactful they are because they don't bring in revenue.
Yeah, it's unfortunate because, this was a service that was really valued by the community, and I'm not sure what the status of that program is anymore. I think anyway, I'll stop there.
I agree. I agree. And Katie, this is a great point that you brought up in the chat as well. A lot of I think what also is that what I found in the research, and it's not going to be in my research, but it was in a presentation that I went to, is providers being open about their lived experiences with serious mental illness. I think that if we use that as a power rather than a hindrance, we could see some of the stigma for serious mental illness and just mental illness overall broken. But I think just like the patients are stigmatized. Of course, a provider with lived experience of serious mental illness or just mental illness overall is going to be blackballed, and their intelligence, their credibility is going to be doubted. And so I think that that's also a huge part of like advocating for peer support too. Yes, I agree, Cassie.
I'll just add that I think interdisciplinary work is so hard, but it's so necessary. I mean, it's kind of easy now that, I'm actually at the School of Social Work, so I'm like surrounded by other social workers, but when you come from a setting where that's not how the lens that everybody sees things, it can be a lot harder, but it's so important. Like, we need social workers in those spaces, because it's so important to see the whole person, and not see everything through a clinical medical lens.
Absolutely. I work currently on a interdisciplinary team for eating disorders, which I very much so view eating disorders as a serious mental illness for sure. And the director of our program has a doctorate in social work, and she approaches this totally different than, maybe a clinical psychologist and things of that sort. And so our team has found to be very successful and very impactful for that specific population of people. And it's just what you said, Amanda, like just all the disciplines bring something different to the table, and we have to give respect to that. And I think that that's what comprehensive care and quality care looks like, is using all of the resources that we can, the perspectives that we can, people that will challenge egos in the room as well, to advocate for the patient. I just think overall this health, and I keep talking about this, but we could talk about this at a later date, but the current healthcare system that we are trying to navigate is very hard to just advocate for the things that are necessary, but not necessarily not necessarily lucrative. And that's what we're fighting against. I don't know about you guys, but I tell people all the time in this research, I would do this for free. I would do this research. I would talk to people. I would teach people about this for free, because it's just so important, and things of that sort. And it's just important work on how to just improve these care experiences, with them also being very expensive, right? A lot of these people are paying, for these appointments, and, yeah. But like I said, Amanda, we could talk about it all night, and I could probably talk to a couple of people on the call about that. But yeah.
So could I. Maybe we'll talk offline.
Yes.
I just want to offer one more opportunity for, any last things that anyone has to say, or any last thoughts that anyone has for Ariel while she's here with us tonight. Okay. Well, so before I thank her, I want to let you all know that our next so don't leave yet. Our next conversation is February 27th. It's obviously a Thursday. These are always on Thursdays at 6:00. Our speaker is also part-time. It's an adjunct here. It's Dr. Samantha Day. Some of you may have had her if you're in the online program. Cameron, does that mean you've had Dr. Day?
Yes, she's amazing.
I know, she's my best friend. I know, she's great. She was in Aruba with me. She is so her expertise is older adults. And I'm excited about her talk because, number one, that's not my area of expertise, just like this wasn't. So I'm learning so much this year. She's also going to talk about the intersection of dementia, delirium, and depression, which is really important if any of you are interested in serious mental illness, because those are often areas where there's a ton of misdiagnosis, just like Ariel was talking about masking. There's a ton of misdiagnosis with those three. So now I am going to thank Ariel. Ariel, I think everyone has said it over and over again. This was incredible. You're getting a lot of thank yous in the chat, which you deserve a ton of. Ariel has been gracious enough to include an email, and Ariel also shared slides. So if you are interested in Ariel's slides, please email me. If you don't have my email, my dog's barking now. You all know that's a problem. Here's my email. All right. Good night, everyone. Thank you all for coming.